Okay, I'm really looking forward to having you back for another episode, Dr. Dubinskaya. I always think you say your name so much more elegant than I say it. So
No, you're
I
actually doing it
apologize
very
if I
well.
butcher it. Um, but I really enjoyed our conversation last time. We talked about prolapse and everything from conservative management to surgical management. And I really appreciate your passion. I can hear your passion. And I love your holistic thinking. You know, you not only think about physios, but you think about, I can tell that you think about the person in front of you, not just their symptoms. And so I thought I'd nab you again for a conversation around something else that's very important to our clients, which is sexual dysfunction. Or it's funny, I hate the term dysfunction. I stumble on that word all the time, but almost like sexual difficulty. Um, and before I get to this, like before we get into the topic, will you introduce yourself again to everybody listening so that they know a little bit more about you?
Of course. Thank you for having me here again. I'm very excited to have another amazing conversation with you. I'm Dr. Alexandra Dubinskaya. I'm a urogynecologist, pelvic sexual medicine specialist here in Los Angeles. I did my training in Russia in the general surgery and then did OBGYN training and female pelvic medicine and reconstructive surgery fellowship in Beverly Hills. So I help women with conditions of pelvic floor disorders like urinary incontinence, pelvic organ prolapse, and I also do treat female sexual dysfunction, any issue with orgasm, arousal, desire. I address those conditions too. And I'm very happy to talk about it. And hopefully, women can learn a little more about it.
That's great. And, I always love to picture the person sitting in front of me listening to this episode. And, I don't think a lot of people think of, let's say, pelvic health, physiotherapy, and sex going together. Like they don't come to see us for issues related to sex necessarily. They might come for things like incontinence, prolapse, maybe pain with penetration, whether it be a tampon or a medical exam. It's usually not sex itself that they come to see us for. But we always ask that question, are you sexually active? How does it feel? Do you experience orgasm? All sorts of different questions. And I can't tell you how many times I hear things like, and we're talking about the female clients today, but I can't tell you how many times I hear things like, oh, I do, but I hate having sex, or I do for my partner, or it hurts. Oh my gosh, I do, but it hurts. And so I really look forward to talking to you a little bit about how does a urogynecologist come at this? Like what lens do you look at this through and what do you have to offer? And throughout this conversation, I look forward to kind of thinking about some of the things that I might be able to offer as a physiotherapist too. I had this conversation with the amazing Dr. Lori Brotto on the podcast. I think it was episode 47. She's a sexual health psychologist, and we talked a little bit about desire and how that's related to sexual function and all the elements that need to fit into place from a psychology point of view. So that was a really interesting episode that I would suggest people listen to. But I'd really like to hear from your point of view some of the things that bring people into your office that bring up this conversation around sex.
Yes. And the thing is that the patients usually come to me with the pelvic floor disorders as well. But why they bothered by those disorders, it's another question. And sexual function and pelvic floor is very much connected. So if something wrong with your pelvic floor organs, there is a very high chance that there is also something wrong or not going as well as you wanted in your sexual life. So in another thing is whenever I do the surgery or do any intervention for pelvic floor, sexual function is one of the outcomes that I consider. So obviously I talk to my patients about how they're functioning, how's this side of life going. And it's very important to not only ask question, but also know how to address it. And if woman comes to me and in her mind, she has an issue with, let's say, orgasm, and she hopes that she, like, let's say she has incontinence, that if I fix her incontinence, her orgasm will improve. But if she never tells me that, if I never ask her about that, she will be trying to get this better outcome of having like a better orgasm after surgery. And there is it's not necessary that it's going to improve after treating urinary incontinence. So it's very important topic to touch base and set the expectations for that as well. And some of the issues, just discussing with women and talking how their process of like sexual response works helps them to navigate where they stand. And a lot of problems can be actually solved without surgery, just by talking and just getting extra knowledge.
I love that. And so would you say then, are you saying that no matter what someone comes in for, whatever they're referred for, whatever they present with, that is something that you'll ask them about? Are you sexually active? Do you want to be? Tell me a little bit about it. Would you say that's something that is a conversation you have with all of your clients?
Yeah, similar how we check like a vital signs with any patient who shows up to the office. We check their blood pressure, their pulse. Um, it's kind of like one of the vital signs for me, because if I'm dealing with that area, it's very important for me to know the status, the status of and function of that area. And I would always usually ask, like, are you sexually active? Are you happy with your sexual activity? Are you sexually active with like men, women? Are you sexually active with yourself? It's all very important points to consider, not only to help with sexual function, but also for me as a surgeon, when I offer you a certain surgical management options, I also need to consider if you, let's say, love and planning to have a vaginal intercourse. So let's say it's not something that on a table and you're not never planning to be sexually active with penetrative sexual intercourse. So I think it's pretty major topic to discuss in my conversations with patients.
Absolutely. And I mean, how much easier is it if you're just used to bringing it up with every person? It takes the pressure off of them. I'm sure nobody's ever asked them this before. And so, how hard that would be going in to talk to a stranger and bringing up some of your most intimate details, where if you're just asked, it's so much easier and I think relieving for them to be asked, isn't it?
Yeah. I mean, some people feel a little like weird about these questions, or because they think that if they're older, it's socially inappropriate to be asked those questions. But I usually also like tell them straightforward, I ask everyone.
Mhm.
Um, so it's not because like something wrong or not wrong with you. It's just I need to know.
I mean, isn't that especially true, like you mentioned with some populations. I find, especially kind of more the geriatric population, I think that a lot of people, they're relieved because I think they almost sometimes feel ashamed that they're still sexually active or that they shouldn't be. But the number of elderly people that come in, and again, it's for me, they're coming to see me more for incontinence or different outlet issues like hemorrhoids or anal pain or something like that. But I always ask, are you sexually active? And most of them are say, yes, I'd like to be, but these are the problems my partner and I are having. And so, yeah, sometimes it's people that I actually don't expect based on maybe their limited mobility or something like that. But I'm always glad that I opened that door for them.
Yeah.
Will you talk about then? Will you talk through then some of the things you're listening for? So, you know, I want you to just educate us on what are some of the things that are in your scope of practice and what you're interested in and what some of your clients share with you and how you approach them.
Yeah. So if we talk about like when we talk about sexual function, I like to basically figure out and pinpoint in which domain of sexual response cycle women has an issue. And I will describe those domains. So it's desire, arousal, orgasm, and resolution. So traditionally, when all the research was done on the males, the sexual response was seen as a kind of like linear model of like, okay, you get desire, you get aroused, you have like orgasm, like erection, orgasm, and resolution. But with women, it's not that linear. And it's more actually a cycle where one domain can go into another domain, and there is no necessary like one start point or like certain end point. So when we're talking about desire, it's important to say that desire, it can be spontaneous. For example, like men often have spontaneous desire where you internally like wanting to have sex. And it could be responsive desire when that generates in response to your partner's desires. So it's kind of like similar to like when you think like, oh, I'm not hungry, and then you try like a piece of food from the plate of your partner, and you're realizing that you've been starving all day and now you want to eat. So and women have both types of desire. Most commonly, they experience responsive desire than spontaneous desire, and it's totally normal. And a lot of women actually say like, oh, I never like really want to have sex. But they never actually engage in sex because they're waiting the moment when they start wanting it. And it's very important to remember that the appetite comes with eating. And I'm not saying like everyone should engage in sexual activity that they don't want, but just trying, just by going there and letting your partner, let's say, initiate and just be responsive to it is actually will generate the desire. And there is also some conditions that can affect desire, and desire by no means like a very constant and stable thing. It's kind of like fluctuate throughout life, and it depends on our hormonal level. For women, like throughout the menstrual cycle, or when women go in menopause, it affects their desire. And also just life conditions like stress at work, exhaustion with like new baby, new puppy, pressing deadlines, relationship issues. They all will affect the desire. And it's very important to recognize them because sometimes it's nothing wrong with a woman. She just needs to kind of take a step back and see like, okay, I'm on a very tight deadline, have a new puppy and two like toddlers. It's normal that I'm not going to have the same desires I had like in college, and just try to work through that. And if that's the issue, referring to the sexual therapist could help, because those people, they definitely have more time during their appointments, and they can actually talk through each particular life situation in details and help women to figure out the ways to how to adjust and what they can like, how they can change what they do in order to get a little better desire. There are also some medical conditions that can affect the desire in a way of, let's say they had a surgery or they had some event that happened that prevents the ability to have sex. So they get a negative experience. And by having negative experience in a sexual encounter, they're more likely to have more likely to expect to have a negative experience in the next encounter. So whenever, let's say, partner making advances, they might feel like, okay, like it didn't work last time, it's not going to work this time, like why would I do it? So it's with that thoughts and with those thoughts in mind, it's also very important to kind of recognize that and work through that. And again, it's not like you're going to get a cure overnight, but just this knowledge can help work around it. There is also a medical condition that called hyperactive sexual desire disorder. And it's basically a chemical disbalance in the brain that not allow women to switch from the mode of like being in the survival mode, where they're thinking about like laundry, kids, do I have a lunch? How's my like work presentation will go, into the reproductive mode when they feeling relaxed and enjoying what's happening, enjoying sexual encounter. And it's a real condition, hyperactive sexual desire disorder. And it's actually, there was studies was done that showed a different level of brain activity in women who has that condition and who don't. And there are treatments available for this condition. There are actually 2 FDA-approved medication that help with the desire, the flibanserin or ADI, or bremelanotide or Vyleesi. One medication is the oral medication that women take every night, and another medication is injection that basically like desire on demand, where women give you themselves injection 40 minutes before they want and can have more improved desire. And these 2 medication, they usually they are approved in women like premenopausal women. However, there is a trial been done, and it showed the same effectiveness in women in like postmenopausal. It just FDA was very particular with the age cutoff. And there are also other medication that has been used off-label to help with hyperactive sexual desire disorder, like testosterone, for example. And it's treatable, and it's very, I think, relieving for women to know that there is a actual real condition. It's in their head, but it's a like there is like physically, chemically something wrong, and we can balance that chemical imbalance and make the desire better.
Mm-hmm. But yes, important for them to realize there's nothing wrong with you. We just have to figure out what's at the heart of this, right?
Exactly. Yes. So this is about the desire. The next domain is arousal. And arousal is basically a physiologic response to sexual desire, and it's to any like sexual stimulation or activity. And women experience increase in heart rate, increase in breathing, body temperature, increase in vaginal lubrication. The vagina gets longer. So what can affect the arousal? If something abnormal, if there is any medical condition going on in any part of your body, it will affect the way how your body reacts. Similar to like basically like, you know, like a heart like stress test. If there is something wrong with your heart, you're going to get abnormal stress test. So for example, any cardiovascular pathology like elevated blood pressure or atherosclerosis, or endocrine pathology like obesity, diabetes, would affect the way how your body reacts and how you experience that arousal. And in relationship to my field, it's important to bring up the genitourinary syndrome of menopause, or as it used to be known as the vaginal atrophy, where due to the deficiency of the hormones, the vulvar and vaginal tissue becomes very atrophic and can't function normally, and it can cause pain, decreased lubrication. And it's very important to address that, because if you have pain in the area that you engaged in sexual activity, obviously it would not be comfortable, and it would create only like more problems. So and this is about the arousal, and you can basically treat the disorders of arousal by improving the medical conditions. Make sure that the hypertension is controlled, make sure the diabetes is controlled, prescribe vaginal estrogens or DHEA for women to improve their like vaginal atrophy. And arousal, the domain of arousal goes into the orgasm. And orgasm is basically culmination of sexual excitement, and it can be accompanied by involuntary muscle contraction. About 15% of women never have an orgasm, and about like 75 to 80% of women can never experience orgasm from vaginal penetration alone, and require to have additional stimulation with additional stimulation of the clitoris. So, and it's also important to kind of remind women that orgasm is not necessarily the goal in our sexual response cycle. For women, it's also normal sometimes to not have an orgasm, but experience pleasure just from being close with a partner, just because they desire to be intimate with the partner, and even desire to pleasure your partner. It's also like nothing wrong with that. It's a normal, very common scenario. And when women know that, you know, I'm not alone, I'm not just the only one who wanna like more interested in pleasing my partner than experience orgasm myself, it's normal, it's okay. But obviously orgasm is a pleasant sensation and experience, so a lot of women want to have that orgasm. And when women never had an orgasm, we call it primary anorgasmia. In that case scenario, usually education and self-stimulation can help, and just teach women where their sexual organs are, like how you can stimulate. There are also several websites that basically guide women through like how to masturbate. Because if you don't know how to deal with your own body, it's very difficult to actually explain to your partner what to do with that. And a secondary anorgasmia is when women used to have an orgasm and then she stopped having them, or the quality of orgasm changed. So with that type of anorgasmia, we usually look for secondary causes, like health conditions, new medications, endocrine disorders, any life stressors, any relationship issues. So you kind of trying to find what else is wrong. And to treat anorgasmia, there are several like very helpful devices like vibrators or suction devices. And actually in the systemic review paper that my team and I we wrote, we looked into the effect of vibrator use on sexual function. And women had improvement in their sexual function in each domain of sexual response cycle. So vibrator is actually good. And it's a really great tool to have because it gives you opportunity to stimulate all surrounding areas that's very sensitive for women. Also using plenty of lubricants, erotica, pornography can help with experiencing orgasm. And kind of like the last domain is resolution, where function of all organs goes back to normal. For men, that domain, that stage of the sexual response is usually refractory, meaning like they can't get aroused more, they can have another erection, they can have another orgasm. Women actually can get aroused more and they can have multiple orgasms in that resolution stage. So we're lucky that way. And it's also very important to explain it to women so they can actually use that opportunity to have a better sexual experience. I know it's a lot of information I just discussed.
No.
Even going like domain by domain and seeing in which domain women has an issue will allow me to help them in a particular way and address that issue. And if we talking about pelvic floor disorders, or we planning to have a surgery, I can actually guide them how like the surgery could potentially affect that particular domain.
I think it's great. I mean, just to be able to lay that out for people, because I picture the people that come in to see someone like you or I, and all they know is that whether I don't enjoy it or I can't experience orgasm, they just feel like something's wrong with them. So I think that just being able to go through this and be able to pinpoint, okay, what do you think the issue actually is? And let's figure out why. I had a couple questions about some of the domains. I thought, you explained GSM for people. That's one condition that definitely affects arousal. And I think too about, what about things like lichen sclerosis or other skin conditions where you can see changes to the clitoris or changes to the vulvar anatomy? I think about those people and how often they don't bring those symptoms up to their care provider, and how like quite often the symptoms turn them away from intercourse, and then it just starts a cycle of that's my bad area, and I don't like how it feels, and I don't have intercourse, and it's hard to get to the bottom of it. What about some of the changes where during, let's say, perimenopause, like you talked a little bit up in desire around hormonal changes or the endocrinology. I see so many people in and around the 40s, mid 40s, 40 to 50, that say everything's changing. Like it's, like you said, it's kind of hitting all the domains. I feel stressed. I don't feel like myself. I feel like my lubrication is changing. What, how would you address somebody like that I think is almost hitting every domain? And where do you start?
Yeah, well, you also brought up a very special category of women 40 to 50. Traditionally, we think about like menopause, oh, it's after 50. Before that, you're perfectly fine. But I think we're forgetting that those hormonal changes, they can start happening like 3 to 7 years before you actually stop having your period. So there are some fluctuation in hormonal level. And the question is how one particular woman is like more sensitive or less sensitive to those hormonal fluctuation. And the vaginal area is actually very, very sensitive to those fluctuations. So sometimes one of the presenting symptoms is just like vaginal dryness. Like I still have periods, but I still have vaginal dryness. So it's also about education and just explaining that it's nothing wrong with you. This is like a life experience. It's just starting to happen. And what we can do, we can help by adding what you start to miss. So some women would go on hormone replacement therapy or on like hormonal birth control to kind of make those fluctuation less drastic, to help maintain the sexual function. And also we were always thought about menopause and changes only related to the estrogen, but testosterone levels are also changing. So repleting testosterone levels could help. And again, for example, for United States right now, testosterone is not, there is no approved formulation for women to use testosterone. It's all considered to be off-label. And but if you struggling to try something for like, let's say 6 months, you can always try and see if it works. Worst case scenario, it's not going to work. And because the field of female sexual medicine is so young, and there's still so many discoveries needs to happen, it's okay to trial different things and see how it works. Obviously, as long as it's not dangerous, but it's reasonable to try and see if it makes you feel better. And if, again, we like to put everything in one big basket and say everything is wrong. So sometimes what helps to actually briefly describe the different domains and what condition could be associated with them, and ask women to put it in like percentage, like, okay, I think most of the, like my issue happens in desire stage. And then when desire is not there, I don't want to engage in sexual activity. I just tell my partners just like, okay, like just do your thing. I'll be just here. So obviously your body is not preparing to be aroused, and obviously you're not enjoying anything. So to figure out what exactly triggers it and how we can change it, educate and change, make small changes, it's definitely like helpful, but it does take time. And sometimes it takes several appointments, not only one appointment, to actually get to the bottom of it. Because again, if women get to the point where she's talking about that openly with a medical professional, it's probably haven't, like that issue have been there for many months, not just a couple of days. So the issue has been being created for several months. So it will take longer than one appointment to figure it out and address it. And it's all normal.
Mm-hmm. I also think another thing I knew that listeners would have a question about is on the topic of orgasm and the clitoris. I think I'm surprised how many times I pull out that pelvic model and show them kind of, this is where the clitoris is. This is our main area of arousal as a female. This is, and these are some of the structures that live underneath that we can't see. What are some of the ways that you describe the clitoris to some of your patients? Because obviously everybody's clitoris is different in anatomy or unique in anatomy, but will you go into a little bit more detail on the clitoris and how important it is for arousal and orgasm?
Yeah, absolutely. And actually, that's also like very important thing to discuss, that clitoris and penis, they have the same embryologic development. And clitoris is basically like a penis. So similar to how penis has a more sensitive areas, clitoris has a more sensitive areas. A lot of sensitive areas in the clitoris we just can't see, and they kind of underneath the skin. So you can always pull out the mirror and show them where those areas are. And it's also one of the reasons why, for example, using vibrators is so helpful for women, because they can cover larger areas and provide the stimulations to the areas that penis cannot go. And I think just also this reassurance and offering them a trial of like vibrator, very helpful as well. And also having the models of the clitoris, of like the vulva with the like clitoris in your office, definitely helps. So actually women can hold it in their hand and like realize where it is.
Hmm. And then how do you describe to them how, let's say, the pelvic floor is related to intercourse?
It's a really good question. So it goes in like, usually like a lot of people who I see, they actually hear like pelvic floor for the first time.
Mm-hmm.
And I'm trying to explain to them that pelvic floor is kind of like a ball that lines our like our pelvic bones. And we have a lot of muscles, a lot of different structures there. So similar to like our shoulders, when we go in a cold environment, we shrug our shoulders and then we get those like painful muscles, painful knots. And sometimes it actually impacts our nerves so much that we can't like move our neck or our head, like arm. And we have to do massage, we have to do therapy for that. Similar thing happens with our pelvic floor. And women love carrying stress in the pelvic floor. And there are so many things happening to women's pelvic floor throughout their life that we just like, because all women are super strong and we just like, okay, we brush it off, we never address it. And then just it comes out of nowhere when it's already been too much. So if your muscles are not functioning properly, if that affects your nerves and it affects your sensation, it's all going to make sex unpleasant. And another very important thing to consider also, if let's say you have a genital urinary syndrome of menopause, you have vaginal dryness, you're trying to have a penetrative intercourse and it's causing you so much pain, pelvic floor muscles, very smart. They will remember that And they will make sure that next time when you're trying to do the same thing, they will be so tight that you will never be able to like have a sex again, penetrative sex again. So pelvic floor is very important to address, and it's so much related to like our mental health, our like general health. So addressing pelvic floor is extremely, extremely important. I think I can't like emphasize that enough.
Yeah, and at the end of the day, I mean, when you go through all of these different domains and you help people understand all the complex factors that go into this, everybody's going to choose something different to address first. Some people would love to see a physical therapist or a physio first. Other people would rather try the estrogen first. I mean, everybody's going to pick something different, but at the end of the day, don't you think any change you make is going to have a trickle down effect and affect so many other things? Like as soon as someone goes on estrogen, if they have uncomfortable tissues, I know that's also indirectly going to help their pelvic floor. Right. And
Yeah.
I think so much of it is education. And I think I ask a lot of times people, I might not even touch them the first time, that we just spend the whole session educating. And I always ask the second time someone comes in, I say, what did you take out of our last appointment? That's what I always ask. And how are you feeling? And the number of them that are like, this is so weird, but I feel better. And I follow that up with, why do you think? Well, because I just understand now. I think the understanding, and you just made me feel not weird or not abnormal, because you when you talk to me, I could tell you have heard this story before or something like that. And so I think, and probably that education we provide our clients or our patients is helping so many of those things, desire, arousal, orgasm, just from the understanding, because they are kind of basic physiological responses that might not be working perfectly, but sometimes our head just kind of gets in the way, our head and our brain and our nervous system, don't you think?
Yeah,
Yeah.
absolutely.
I listen to you and I think, how refreshing is this? I don't think that everybody by any stretch of the imagination gets this conversation with their specialist when they go to see them. And I know that there's so many limitations in our healthcare systems. I know we do not have perfect healthcare systems, but I'm curious to know, um, does all of this stuff that you and I talked about today, does this come in your regular training in gynecology or urology? Like, is this something that people are learning now in school, or is this extra training that you've had?
Yeah, so unfortunately, it was the extra training. There is no special curriculum yet in like gynecology or OBGYN residency. Urology, they do learn more about male side, but not as much in female side. So there are actually special fellowship in a sexual medicine in United States, very limited spots, but where you can actually like specifically focus on it. There is an amazing society called ISHWISH, International Society for Study of Women's Sexual Health, that has a lot of good resources for providers from different specialties, like gynecology, urology, pelvic floor physical therapist, like just psychotherapist, way that helps educate them and learn more. So everything that I learned, I had to basically dig on my own. And I'm very grateful to that society and to all people who been in that like in that area of like science, so I can learn and I can educate my patient and I can provide them with appropriate care.
Your system down in the States is different than ours in that you have more of a system that please correct me if I'm saying any of this wrong, but that I know that you're still limited. If you work kind of in the traditional model, you're still limited to shorter appointment times, which always eliminates how much you're able to discuss in your appointment time. So I know that you have down in the States, you have the opportunity of having your own clinic, and setting up longer appointment times and stuff like that, so that when people come to see you, you're able to provide a bit more of your time and a bit more information. And I'm totally putting you on the spot here, but I'm curious to know, for in a system like ours, for example, in Canada, I think about this and I think, by no means are our care providers not kind. It's not that they don't care, and it's not that they don't see these issues, but I think we're always up against this time and how our system works. But do you have any suggestions, given that that is a barrier for people to receiving information? So if someone's listening to this and maybe they live in my community, or they live in Canada, or they live in a place where you aren't, what are their options if maybe they're having symptoms and they have a gynecologist or they have a urologist, but sexual health is not coming up in their appointments? Do you have some suggestions?
Yeah, unfortunately, it is a big problem. And it's, I think, problem not only Canada, also in United States, where somehow with their physicians, we got ourselves in a situation where insurance running out time and running the way how like we doing the practice of medicine. It's very unfortunate. And that's what I agree with you. That's what makes some people, like, for example, like me, to step out of that system and try to do my private practice where I can spend longer like time with the patient and address all this issue instead of just like doing like a small patching. It does come with price when like I can take insurance, so to be able to allow myself to spend longer time with the patient. But when I think about, do I want to provide quality or quantity, quality wins. So I have to do that. I know that Canada is a little bit more stricter on the system, that you can't really go and do like and be a private provider. I think like looking for the physician, because there are like no one physician is the same, as you said before. There are some physicians who has more interest in sexual function and dysfunction. And I'm sure it will come up if you're going to start looking and just showing to the appointment and maybe telling your provider, I have this problem and I know we can't address it right away, but can we try to do it over like several appointments, try little by little, and maybe we'll find the ways. And also self-education as well, that society, that website that I mentioned, the Ishwish, they actually have a website called Prosalia, where you can find the information and read up on your condition. And I think nowadays in the world of like Google and WebMD and everything, patients are very educated. So just also trying on your own, finding it. And if you just also sometimes just bringing that information to your physician and just sharing like, this is what I think is wrong with me, can you help me? And I know you might not have an answer right now, but can you like give me an answer like next month when I come see you? I think that could be one of the ways to solve it. I know it's not a perfect answer, but
Well, I think unfortunately we're just coming, well, we're still living in it, but I think we're starting to see change in. There used to be kind of like way more of a hierarchy where the patient would just show up and expect the physician to um you know to be able to. I guess what I'm trying to say is patients were never in their own driver's seat, right? There wasn't a lot of patient autonomy. And I think that's really coming. So I think that some of that is on us as patients to be able to do our homework and educate ourselves instead of put all that onus on someone else in a 10-minute appointment. Because I do think that's kind of unfair to the physicians if we expect them to remember everything about us and do all the homework before they see us in 10 minutes. So as you mentioned, doing our own homework, educating ourselves from good quality resources, but I think also doing the homework to find the right practitioner, because I think that's what you're saying is all of the physicians have their own kind of specialty or their own interest area, and you might need to do some asking around or some digging in your community, and it's okay to ask for a referral to that person, right? I mean, I think sometimes we worry about being an easy client, or I don't want to be difficult, but it is your body and your life. And if there's someone that you want to see, some of that background homework on your part, I think is helpful.
yeah.
Right. And also too, I know there's a space for just, there's so many different, you know, I've listened to several different, like we've talked before about some of the care providers in the States, like Dr. Rachel Rubin, and yourself is starting to create more information. Also, different podcasts that physicians put out that they're providing a lot of information. So at least you trust the source, but they always in those, whether they're YouTube videos or podcasts, they give suggestions because not everybody lives in their community. They give suggestions of where to go from there. Yeah. What else have I not asked you about that we should make sure we cover in this discussion? I want you to really quickly tell everybody again where they would find you. I will put all this in the show notes, but where they find you, the name of your clinic, and anything else about yourself that you want people to know.
Okay. So, well, my name is Alexandra Dubinskaya. I can be found in Beverly Hills in Los Angeles, California. I'm opening my private practice probably by the time this episodes will come out. I will be clinic will be open, and I'm seeing women with pelvic floor disorders as a pelvic organ prolapse, incontinence, urinary tract infection, and sexual dysfunction. So any issues in desire, arousal, orgasm, I can help with that. And you have my website, drurogyne.com. You can find me there and make appointment from that website. And I think the important points that I want women to remember is that never take your sexual health for granted. And remember that sexual function in sexual health is like any area of your life. It's like working on your perfect body or on your work project. It takes time and it takes discussion, it takes planning, and it's normal. Nobody has a perfect life. Nobody has like having a hot sex every day like in the movies. It all takes planning and time, and it's all normal. It's all expected. Any dysfunction, any issues in like sexual response in sexual life is common. And the good thing, there are more and more providers coming out who are well trained to help with those conditions. And there are more and more medications available and treatment modalities that can be offered. So it's very important to keep searching and not give up your hopes, because I'm sure you can always find the provider who can help.
Awesome. Well, I thank you so much for your time, and your patients are really lucky to have you because, like I said, I can tell that you really listen to the person and think about the whole person in front of you, and you don't just see them like a vagina. I can see that. So
Thank you
thank you.
so much, Mel. It's a pleasure being on your podcast.